Assalamualaikum students, and welcome to your ophthalmology lecture video sessions. We are continuing on with the theme of red eye, and we are on to our final differential, which is eye trauma. Um, you can have various types of eye trauma, something from as innocuous as a bruise to something as sight-threatening as an optic nerve avulsion. Thus, the presentation of a patient is very variable. So most of the time you do have a red eye, but that red eye is of variable intensity, and the pain uh, obviously will be of various intensity as well, depending upon the severity of trauma and the location of trauma as well. So we'll talk about these things today. We will talk about the relevant anatomy. We will classify trauma in a way that is the easiest for graduate students or undergraduate students. We will have a very bird's eye overview of traumatic injuries, and we will talk about their management as well, since here recognition that trauma has occurred and the implications of trauma are more important than management, because obviously as fresh graduates, family physicians, with the possible exception of a couple of things, most of the times these patients would be ending up in an ER or or with an ophthalmologist. So your job here is to recognize that, yeah, this trauma is something that requires a specialist attention, and what you can do to ensure that the visual outcomes after the trauma has occurred would be optimum, and that's about it. So we'll start off with the anatomy of the orbit, and these are the various bones that make up the various walls of the orbit. The floor and the roof are also included in the walls of the orbit. The floor is of sort of more importance here, and we will see why that is in a bit. But these are the boundaries and the various bones. There's nothing new here. I'm sure you have seen this picture countless times, or pictures like this, or even seen a real skull. This is just an animation showing you the extraocular muscles. Again, our emphasis is going to be on the muscles that are closer to the floor. So what we are looking at is inferior rectus, which arises from the orbital apex and inserts into the inferior aspect of the eyeball, and it travels very close along the floor of the orbit. We also have the inferior oblique, which arises very anteriorly from the medial side of the orbit and is inserted into the posterior, inferior, and lateral quadrant of the eyeball. But the inferior oblique is very interiorly placed into the orbit. It's the inferior rectus that has the greatest distance traveling, and this will give you a better idea. So it arises from the orbital apex somewhere here and travels along the floor across most of the length of the floor. And this view is taken as if by removing the maxillary sinus. So the camera is within the maxillary sinus, and you can see some teeth here as well. This is the cavity of the maxillary sinus, and this is the inferior rectus muscle, and this is going to be of our focus for this animation. These are the rest of the muscles, but again, this muscle, inferior rectus, and its close association with the floor is what we are looking at right now. Just one more picture which tells you, here we go, this one, how it sort of runs all along the floor, very close approximation. So any damage to the floor would result in loss of function of the inferior rectus, and then that loss of function would lead to some other changes, as we will see. This is the inferior oblique. As you can see, it arises anteriorly from the medial side of the orbit and inserts posteriorly, superiorly, and laterally onto the eyeball, but it's very interiorly placed. So it's the inferior rectus that has the greatest association with the floor of the orbit. So these are just the various bones that make up the various walls. Again, nothing new here. Nothing has changed since you were doing SPS. So really, I can't add anything here. These are the contents of the orbit, and just like the boundaries or the bones of the orbit, these are all what they were before. Again, nothing new has been discovered in the meantime, since you had moved from second year to fourth year. This is an animation of the eyeball, and the reason this is here is to show you that the trauma, depending upon its intensity, could affect the eyeball all the way from the interior structures, which is the cornea, all the way to the optic nerve here, depending upon the force of the object, the size of the object, and the momentum of the object. So various structures could be damaged, which would be the cornea, and inside of the cornea would be the aqueous humor, the iris, the ciliary body, uh, the sclera, which is associated with the cornea. So all of these structures could be damaged, and we'll just remove these structures and see them one by one. So we've removed the cornea. This is the aqueous humor, and if you remove the aqueous humor, we would get to the iris. And this is the sclera, which can be damaged together or in isolation with the cornea. So now this is the iris, and this is the lens, and all of these structures, and not necessarily just one structures, depending upon the force of the object, the affected structures could be the cornea or the iris, or the cornea, iris, and the lens, cornea, iris, lens, even the retina, depending again on the force of the impact, the size of the object causing the impact. So we are just removing various structures, and now we are looking at the retina. This is the vitreous. So again, and now we removed the vitreous, and this is just the retina. This is the optic. Now again, this is an animation. This is not a real picture, but this gives you an idea as to the three-dimensional nature of the eyeball and how various tissues would be damaged. And the important thing here is to understand that if you remember from forensic medicine, compression, decompression injuries, most of the structures at the posterior half of the eye, and even the interior half, the interior segment and the posterior segment, I'm sure you remember segments from when we were talking about cataract, they are affected both by compression and decompression forces. The optic nerve is more severely affected by the decompression nature of the forces, as we will see. The structures in the interior half are affected both by compression and decompression. So these are the segments and chambers. The anterior chamber was the space between the cornea and the iris. The posterior chamber was basically the lens. It's the space behind the iris and in front of the vitreous, and it contains the lens. The anterior chamber together with the posterior chamber form the anterior segment. The posterior segment is behind the posterior chamber, or the entire anterior segment, and generally consists of the vitreous, the retina, the choroid, and the sclera. This is a picture of the posterior pole of the eye. This is the fovea. This is the foveal reflex. I'm sure you know why this is here. This is the macula, which is the part of the retina between the first major division of the central retinal artery, and everything beyond this can be described as an extramacular area. This is the optic nerve. The optic nerve together with the macula is referred to as the posterior pole of the eye. So this is how we classify trauma, and this is one of the simpler classifications. Again, there is no really agreed upon terminology for classification. There is one called Birmingham eye trauma terminology, but even that has very limited sort of use. So this is the way we classify trauma. We classify it as blunt, something that is caused by an object that is not sharp, and this could affect the orbit and or the adnexa in the eyeball, depending upon its size and where it hits. You can have surface trauma, which basically consists of erosions and lacerations. You can have perforations and penetration of the eyeball, chemical trauma, and certain types of trauma that are sort of difficult to classify anywhere else. We'll start off by blunt trauma. And as you shall see as we go along this presentation, it's very different from what we have done before. More pictures, less text, because again, as I said, recognition is more important here than any aspect of management, and wherever management is important, we will talk about it in some level of detail. So as I said, blunt trauma can affect the orbit, the eyeball, and the adnexa, or a combination thereof, depending upon its size and where it hits. Generally speaking, smaller objects tend to damage the eyeball and soft tissues because they tend to hit the eyeball because of their size, and larger objects tend to damage the bony orbit because the bony orbit protrudes in front of the eyeball, so it has some protective function. So if you have a large object, it tends to damage or transfer its force to the orbit. Smaller objects transfer their force to the eyeball and would cause varying amount of damage. But it is possible for a larger object to hit in a way so as to cause damage to both the eyeball as well as the bony orbit. For example, if I'm punching myself like this, it's generally the orbit, but like this or this would affect the eyeball as well as the orbit. But generally speaking, the rule is larger objects, orbit, smaller objects, eyeball. This is blunt trauma to the orbit, and it is caused by larger objects, baseball bats, baseballs, tennis rackets, tennis balls, hockey sticks, hockey ball, cricket bat, cricket balls. And what they do is they tend to transfer their force to the bony orbit. Because of their size, they tend to hit the orbital margins rather than the eyeball. And as they transfer their energy, they can potentially damage any of the orbital walls. And it is the floor that is the one that is most commonly damaged. And as you can see in this CT scan here, the left orbit has a fracture of the floor, and you can see herniation of the orbital fat into the maxillary sinus. This is a picture of a person who experienced trauma to the eye. And again, as you can see, this time it is the right orbit, and you can again see that there is a fracture of the floor, which causes herniation of some amount of orbital fat. And also, if you look at the eye, the position of the eye, the left eye is lower than the right eye. And that is simply because as the fat herniates, there is not enough cushion inferiorly, and the eyeball is displaced inferiorly, which is described as dystopia. Any fracture of any of the orbital walls is called a blowout fracture because the walls simply blow out. You can also see that in addition to the floor, there is also some fracture of the medial wall, causing herniation into the paranasal sinuses. Where is the orbit likely to fracture the most? Well, that is the floor. Any fracture of any of the walls of the orbit is called a blowout fracture. We talked about that. And the most common fracture is of the floor of the orbit. And that's basically simply because of transmission of force from the object to the orbital walls. And as I've also described before, it is possible to see damage to the adnexa and the eyeball together with damage to the orbital walls, depending upon how the object hit. We'll talk about damage to the adnexa and the eyeball next momentarily, once we have completed damage to the orbit. So what do you see? Basically, you can see damage, the effects of the damage to the orbit and as well as the surrounding tissue. So you are likely to see some bruising around the eye of the lids, as we saw in the picture before. Let me just bring that picture back in right here. A bruise can be seen simply because of transmission of the force, causing rupture of some blood vessels. And you can also see the same in the conjunctiva, which is then called a subconjunctival hemorrhage. That is because of damage to the subconjunctival vessels and or the orbital vessels. We'll see the mechanism of subconjunctival hemorrhage when we talk about trauma to the eyeball and adnexa, but obviously you can see it in association with damage or trauma to the orbit. Simply because, you know, we have talked about it before, depending upon how the object hits, it can damage the orbit and also the soft tissues. With specific regards to what happens when the floor fractures, remember we are now talking about the orbital floor fracture because that's the most common variety. You see enophthalmos. Enophthalmos is basically an eye that's sunken inwards. It's the opposite of exophthalmos, and that's happening because the orbital fat herniates through the fracture in the floor into the maxillary sinus. Now the orbital volume has increased and the eyeball simply sinks back. Vertical diplopia, and we saw the association between the inferior rectus and the floor when we were seeing the animation of the extraocular muscles. If you have a fracture of the floor and the inferior rectus is running all across the length of the floor, the inferior rectus can get trapped into the fracture and it wouldn't allow the eyeball to rotate downwards. Not only that, when the eyeball tries to rotate upwards, it won't let the elevators of the eye, name of which one is the superior rectus, work properly, simply because it's stuck and it's not letting the other muscle work as well. So you have diplopia or double vision if you look up or down. And that is because of just one muscle being trapped, not allowing the other muscle to work as well. You also have lower lid anesthesia, loss of sensations, and that is because of damage to the infraorbital nerve, which travels along the floor of the orbit. And then finally, you would have dystopia. We've seen dystopia before, and that happens because once you have a fracture, the orbital volume increases, and you have that herniation, as we talked about when we were talking about enophthalmos, well, just 2 points ago. and as the fat herniates and the volume increases, the eyeball sinks not only backwards and downwards as well. We'll see all of these again. We have seen dystopia once already. So this is again showing you the association of the inferior rectus muscle with the orbit. We are seeing this as if the camera is in the maxillary sinus. This is the cavity of the maxillary sinus. And if there is a fracture of the floor here, the inferior rectus can get trapped easily. The inferior oblique is too interiorly placed to be affected by most fractures. And this is how the muscle would sort of be entrapped into through the fracture into the maxillary sinus. This is dystopia, and this is to the left eye. Look at how the upper lid is lower, and that's because the eyeball is sunken. It's also inophthalmotic, or there is enophthalmos because the eye appears sunken in. Now, some of you might say this can also be ptosis, drooping of the upper lid. But there is a very simple way of checking that, and that is by performing the levator function. We'll get back to levator function. This is how you check enophthalmos. You place a scale at the lateral canthus, and you are trying to eyeball the position of the apex of the cornea to a point on the scale and measure the distance. You do it for both of the eyes, and that will tell you if there is an enophthalmos or not. This is how you differentiate between ptosis and enophthalmos. Simply check the levator function. Levator function, if you have not done the scale yet, we have an entire video on ptosis and levator function, so you can see that clinical skill video. But briefly, what you do is you place your thumb on the brow, make the patient look down, and then make him look up to see how well the levator is working. In enophthalmos, the levator function should be fine because nothing happened to the levator muscle. In ptosis, the levator muscle would be affected. So that'll tell you if this is an eyeball that's sunken, that is sort of mimicking an enophthalmos, or this is ptosis proper. Oh, an eyeball that is sunken and is causing an enophthalmos, or mimicking a ptosis. And you check that by doing a levator function. If the levator function is normal, it is enophthalmos. If the levator function is affected, it's likely to be ptosis. So what do we do? Most of the time, the enophthalmos is not significant and it's not cosmetically undesirable, so nothing. And if there is no diplopia in down gaze is more important than up gaze because you read in down gaze. So if there is no diplopia in down gaze and enophthalmos is less than 2 millimeters, but by what does 2 millimeter mean? Well, the difference between the position of the apex of the cornea is less than 2 millimeters between the two eyes. You don't do anything. If there is a greater enophthalmos, or you have a diplopia that is in down gaze, you need to repair the defect. And what you do is you push the contents of the orbital cavity back up, and you cover your defect. And the defect is covered. Sorry, my cable is bothering me. Your defect is covered either by using a Teflon plate. Teflon is something that you use in non-stick pans, so it allows muscles to move freely without any friction. You can also use a bone graft, whatever is available to you. Now we'll talk about trauma to the adnexa in the eyeball. And remember, largely the rule is that smaller objects affect the eyeball, larger objects affect the orbit, as we just talked about the fracture of the floor of the orbit. But it is possible for smaller objects to cause damage to the orbit as well, depending upon how they hit, and also for larger objects to cause damage to the eyeball, again, depending upon how they hit. So these are the smaller objects, golf balls. I've seen golf ball shattering eyes. It's really bad. Squash balls, billiard cues more than billiard balls, and bottle tops. Bottle tops hitting a person the wrong way can be very, very damaging. So as we've already talked about, that depending upon the momentum of the object, how fast the object is traveling, and how much energy it can transfer to the eyeball, you can see damage just to the adnexa, or the adnexa and the eyeball as well. And if the eyeball is involved, it can be involved to various extent, all the way from the cornea anteriorly to the optic nerve posteriorly, depending how much transmission of force has occurred and how many structures are damaged by the transmission of the force. A general rule of the thumb is greater the momentum, greater the damage, i.e. more posterior structures within the eyeball can be damaged. So again, as we have talked about before, the damage could be something as benign or as innocuous as a bruise, and something as sight-threatening as an optic nerve avulsion. So this is just a picture showing you, just a picture. This is just a picture showing you the various structures of the eyeball and well, it shows the lid, it's not labeled here. So damage can be anywhere extending from here, the very anterior structures, all the way back to the optic nerve, depending upon how fast the object is traveling, and also how it hit the eyeball. With an open eye, most of the time you close your eyes, because whenever you see something fast approaching you, so you close your eyes, so you start the damage off from the lid. If your eyes were open, obviously the damage will start off generally from the cornea. And again, remember, smaller objects can also damage the orbital walls depending upon how they hit the eye. So bruise, it's called ecchymosis, collection of blood in soft tissues. Chymosis is a special term used to describe conjunctival edema. Ecchymosis is a general term that is used to describe a bruise or collection of blood in soft tissues. Black eye, panda eyes, bruise in both eyes. This is a subconjunctival hemorrhage, and when you're looking at a subconjunctival hemorrhage, the most important thing is to see if you can find the posterior limit of the hemorrhage, and that's also important as a graduate and also as a family physician. If you can find a posterior limit to the hemorrhage, that means that you can see some clear areas behind the hemorrhage. That means this blood is coming from conjunctival vessels. But if there is no clearing, that means there is a likelihood that this blood is coming from orbital vessels, and there are orbital vessels that have ruptured. So it's really important to see this. In this case, you can see clearing here and here. So this hemorrhage is from conjunctival vessels. The origin of the hemorrhage is from conjunctival vessels, as opposed to this, where there are no posterior limits, and obviously you move the eye in all directions before you make a judgment. But in this case, there was no posterior limit that can be seen, and it is very likely that this blood has accumulated into the conjunctival sac from a ruptured orbital vessel. You can also see an accompanying ecchymosis or a bruise here as well. So this is just a very small animation showing you what I mean when I say where the hemorrhage is coming from. So this is the conjunctiva. This is the conjunctival fornix. This is going to be the bulbar conjunctiva, and this is the palpebral conjunctiva. This is the lower lid. And this is an orbital vessel. So I've labeled this as well. So any hemorrhage occurring in the orbital space can seep through into the conjunctiva, and this is how you would see this hemorrhage. The reason you don't see a posterior limit is because blood is coming from a posterior source. So there is no posterior clearing, because that's where the blood is oozing in into the conjunctiva. This is because, in all likelihood, because of an orbital vessel getting damaged, which is feeding blood into the conjunctiva, and you can't see any posterior limits to the hemorrhage, as opposed to this picture where you can see posterior limit. So this is more benign, because these are just conjunctival vessels. They have ruptured. This hemorrhage would be absorbed back. This is more dangerous, because a hemorrhage in an orbit can compress an optic nerve, and that can lead to sight loss. So this is more dangerous as compared to a subconjunctival hemorrhage of a conjunctival source, because the damage is limited to the conjunctival area as well, and that's usually almost always benign. So moving on, we have talked about damage to the lids. We are now talking about damage to the anterior structures of the eye, and we'll start off with the iris and the anterior chamber. And the iris vessels could rupture just like conjunctival vessels ruptured, and they can result in blood in the anterior chamber, which is called hyphema. We've talked about hyphema when we talked about angle closure and new vascularization of the iris, leading to blood in the anterior chamber. Blood in the anterior chamber can also collect because of trauma, and this is hyphema. And this hyphema can clot and cause blockage of the anterior chamber angle. And hyphema itself, because it's raising the volume of the anterior chamber of the eye, can cause a rise in pressure. This is called iridodialysis, and if you see right here, the iris seems to have been torn off from its root, its attachment to the ciliary body. If you remember our discussion of open angle glaucoma, The iris is attached to the ciliary body. I'll put the picture up next to show you, or the animation, a bit of the animation that we saw, or a frame of the animation that's we saw when we were doing open angle glaucoma, as to how the iris is attached to the ciliary body. So here the iris has detached from the ciliary body, and this is called iridodialysis. Dialysis means to separate, and you must have heard the term dialysis in reference to renal failure. And those renal dialysis basically means to separate, because you are separating waste products through that dialysis machine. So dialysis means to separate. And the problem here is that when the iris separates, it can scar the ciliary body. And because iris was forming a part of the anterior chamber angle structures, once it is detached and it causes inflammation, it can actually block the angle in the area of the dialysis. This is the picture we saw when we were talking about open angle glaucoma. And this is just showing you the association between the iris and the ciliary body, right here. And this is where the iris is torn from its attachment to the ciliary body, leading to iridodialysis. These are just the other structures that we had labeled in that diagram, but our focus right now is this area where the iris attaches to the ciliary body. It's torn, leading to iridodialysis. And in this area, if there is any scarring, it can easily block the anterior chamber angle, these structures right here, leading to glaucoma. In the long run, obviously, once you have your visual field effects and your optic discoupling, it would just cause a rise in pressure before that. So these, moving on from the iris to the lens, remember we're talking about potential damage to the eyeball structures depending upon the momentum of the object that's hit the eye. So we could have just a bruise, or we could have bruise plus damage to additional structures. And that is why it's so important to open the eye if the bruise is severe enough to cause ptosis. So you have to open the eye to see inside whether everything is okay or not. You just don't say, oh, this is a bruise, and we'll just manage the bruise. There could be damage to structures within the eye. So always open the eye to see what other structures have been damaged. We talked about damage to the iris. Behind the iris is the lens, and in the lens you can have a cataract, and this is a sunflower cataract. We've also seen this picture when we were talking about cataracts. This is on a distant ophthalmoscopic view. This is on a torch view. And the other thing that trauma can cause in addition to a cataract is a dislocation or subluxation of the lens. And that is happening because if you see here in the picture on the left, you can have damage to the zonules because of the blunt trauma, which would break the zonules, and the lens can dislocate in the direction where the zonules are still present, because those zonules will pull the lens. So this would indicate an inferior dislocation because the superior zonules are broken. And this can lead to diplopia, because now you'll have light going in through this part where the power is only 18 diopters, 42 diopters, just the power of the cornea, and here it will be 60 diopters. So you'll get diplopia when you have your eyes open. Although one image would be very blurry, you would still get two images. Well, this rather complicated appearing picture is not complicated at all if you just, keep your wits about you. What you see are basically two different pathologies here. One is rather easy to figure out, and that is lens subluxation or dislocation. And this is the superior border of the lens, and the lens has been dislocated or subluxated inferiorly. Because the superior zonules are broken, the zonules right here, I'm pointing to them in the picture on the left, and the lens has dislocated inferiorly. The other thing you see is this. So I'll just put up the dislocation here, or subluxation. Dislocation and subluxation can be used interchangeably, although there is a little bit of difference between the two, but using it interchangeably is sort of okay. And this is the iridodialysis. So the iris has torn off from the ciliary body, and rather than inferior tear, which we saw before, this is more of a vertical tear happening in all likelihood from the medial side. And this is your pupil, which has now taken a pear shape, and that is simply because of the iridodialysis, which is pushing the entire pupil into this odd shape. So you are seeing iridodialysis together with lens subluxation in this picture. Moving behind, we have done iris, we have done lens, and in part the ciliary body, because we talked about how damage to the iris results in iridodialysis, which can cause fibrosis in that area and can cause glaucoma. So we have talked about iris and in part the ciliary body, then the lens, and now the vitreous and the retina. And because of blunt trauma, you can have damage or rupture to the retinal vessels, causing retinal hemorrhages. And if you have retinal hemorrhages, retinal details are obscured because the hemorrhage is over it. You can also get a hemorrhage in the subhyaloid space. We talked about these when we were talking about diabetic retinopathy, and as just a revision, this is a hemorrhage in the space between the posterior face of the vitreous and the retina, and it has this characteristic boat shape or a D shape. So this is called a subhyaloid vitreous hemorrhage. And if you remember this picture, a retinal hemorrhage is something that is within the retina. A subretinal hemorrhage is something that's below it. And we talked about that when we talked about age-related macular degeneration, the wet or the neovascular type. And a subhyaloid hemorrhage is between the retina and the posterior face of the vitreous. So this is the posterior face of the vitreous. By the posterior face, I mean the posterior boundary of the vitreous. So the blood has accumulated between the vitreous and the retina, which is then called a subhyaloid hemorrhage. So in response to the trauma, you can also have the blood from the retina collecting in the vitreous, which causes a vitreous hemorrhage. And vitreous hemorrhage appears as a cloud of blood in the vitreous space, which makes everything in behind it difficult to visualize, as opposed to retinal hemorrhages, which have a certain boundary to it because it's happening within the retina. Vitreous hemorrhages have no boundary because it's like, blood diffusing into the vitreous cavity, and so it's like a cloud. And the patient can also sort of at times say that it's like there's a cloud in front of my eye. And some really intelligent people would say, I see everything as red simply because the blood is red, and that is called erythropsia. It's a term that you will not see in many new books, but that's a term that still does exist. So this is the other thing that can happen with the trauma, and that is a retinal detachment, as shown by this area here. So the area above the white line is all detached, and that is because the excessive force of the trauma produced tears in the retina, which cause the retina to detach. We'll talk more about retinal detachment when we talk about retinal detachment, when we do our sudden painless loss of vision theme. But suffice to say that trauma can also cause retinal detachment. We started off anteriorly, started talking about the iris, the ciliary body partially, the lens, and then the vitreous and the retina. And within the context of the retina, we talked about various types of hemorrhages and now retinal detachment. This is the most devastating result of blunt trauma to the eye, and that is optic nerve avulsion. Optic nerve avulsion is simply explained as separation of the optic nerve from the eyeball without actually any damage to the surrounding sclera or the walls of the optic nerve, i.e. the optic nerve sheath. And one of the best ways of explaining this is to look at this animation right here. It's like if the cork of the bottle is the optic nerve and the bottle is the eyeball, this is what happens during trauma. The nerve simply separates from the eyeball, and it results in this rather large hemorrhage around the optic nerve simply because all the nutrient vessels within the optic nerve are ruptured because there is a separation between the nerve and the eyeball. Externally, if you see the sheath or the covering of the optic nerve is still attached to the sclera, it's the substance or everything within it that's completely separated from it. And it results in devastating visual loss, no perception of light if it is a complete optic nerve avulsion. This is another patient who has a unilateral optic nerve avulsion. Again, you can see hemorrhage around the optic nerve and within the optic nerve simply because of rupture of the nutrient vessels. This is an MRI, and as you can see from the green arrows, the optic nerve is separate from the eyeball right here. And here you can see the optic nerve is attached to the eyeball here, where between the green arrows where my pointer is. This is where the optic nerve has separated from the eyeball. This is a mechanism explaining the optic nerve avulsion, and it is basically the deacceleration or the decompression phase of the injury when the eyeball is trying to get back to its position after being compressed or being accelerated in a trauma situation. And as it is deaccelerating, the various velocities of deacceleration between the optic nerve and the eyeball leads to the separation of the nerve from the eyeball. So this is the last structure. We started off anteriorly from the iris all the way back to the optic nerve, and we saw various amounts of damage, various types of damage, and we'll just summarize them here. And this is the most important thing, and I'll leave it blinking so that you don't forget. It is always open the eye to see the extent of trauma in case of mechanical ptosis in response to trauma. You have to open the eye to see how much damage has occurred. And we've talked about damage to adnexa, ocular surface, anterior segment. We talked about damage to the posterior segment. And in some of these cases, retinal detachment, optic nerve avulsion, you can see an RAPD because enough of the retina has damage. In retinal detachment, if enough of the retina is detached, you'll see an RAPD. In optic nerve avulsion, almost always, unilateral optic nerve avulsion, you will see an RAPD. In bilateral optic nerve avulsion, obviously you won't because both optic nerves are sort of damaged. So what do we do? For chemosis or ecchymosis, most of the time just observe or give painkillers, and that is enough. For iridodialysis, if it is small, do nothing. If it's larger, it needs to be repaired because inflammation in this area can lead to fibrosis and angle closure. Hyphema can cause a rise in pressure. If the rise in pressure is less than 40, it is usually okay because the hyphema is not enough and it will just be cleared normally. If the pressure is more than 40, you would need to evacuate the hyphema. Paracentesis can be done. And if you remember discussion of angle closure, you should know what paracentesis is. Cataract lens dislocation, cataract or lens dislocation would require surgery. If you have vitreous or subhyaloid hemorrhage, you can observe if it's small. If it's non-clearing or larger, you would need to do vitrectomy. What is vitrectomy? We'll talk about when we do retinal detachment. It's more relevant there. If you have retinal detachment, you would need repair. We would again talk about it when we talk about retinal detachment. And optic nerve avulsion, just observation. You can't do anything. Whatever nerve has separated has separated. And now we have done blunt trauma, which is the most important bit, and we are moving on to surface trauma. Surface trauma is usually in response to sharp objects, especially these artificial fingernails. I've seen these do amazing amounts of surface trauma. Metal shrapnels, these are basically grindings, metal shavings, sorry, which usually are produced when you are grinding metal and you're not taking you're not wearing proper eye protection, so you get eye trauma because of it. Most surface trauma does resolve on its own. You don't really need to do much, not much, or in the sense of surgical intervention, unless of course you have lacerations or something, which we will just see. So this is the most common type of surface trauma that you see, and this is basically a corneal abrasion, and it has been stained, and this is because of a nail, a baby's nail or your own nail, and you're just trying to go straight like this, not knowing, or you've forgotten that you're wearing an artificial nail, or your nails are really long, or your baby has hit you with a nail. So you get this linear scarring. This is a foreign body that's strapped in the palpebral conjunctiva of the upper lid. It's basically you're not using eye protection and you're doing metal work. This is a similar foreign body. This time it's on the cornea. You can see a little bit of rust that sort of seeped into the cornea. And this is something that would definitely require repair. This is a laceration of the lower lid. Again, usually metal workers, or if you get into a really bad fight, you would get this. Most of the time you can just stitch it. If it's large, you might require a flap, but that's hardly ever the case. It's usually just direct repair that is usually enough. If it happens close to the medial canthus and the lacrimal drainage system is involved, you need to be careful so as to appropriately make sure that the drainage system is patent, and you do that by putting in that silicone tube into the system through the probe so that the lacrimal system heals in continuation, so that the patient does not complain of watering after the trauma. This is very interesting, and this is basically electric arc welding and response of the eye to electric arc welding. Electric arc welding produces a lot of blue light, ultraviolet light. That is why people who do electric welding usually wear special type of UV blocking glasses or protective eye shields. And if you don't, what you end up with are these minute hundreds of tiny corneal erosions, which are called PEEs, which are punctate epithelial erosions. There are many because this is the area where the cornea has absorbed ultraviolet light. Cornea absorbs a lot of ultraviolet light, does not let it reach the retina, so it's sort of a filter. And because there is so much blue light in electric welding, which is close to the ultraviolet spectrum, Webb Gear or Roy Gibbs, depending upon how you remember the visible spectrum of light. The closer you are to ultraviolet, that means your visible light is going to have a blue hue or a blue color, and electric welding has that. So that ultraviolet light is absorbed by the cornea, produces these tiny punctate epithelial erosions, and exposes corneal nerves, and they are painful. They are amazingly painful, so painful that the person thinks that he's going to go blind. The good part is between 24 and 48 hours, the cornea pretty much repairs itself and you're good to go. But it is scary, and that is why that protection that is given when you do electric welding is so important, because it prevents you from getting this. It is a rather benign condition, but it is a very painful condition. So how is this surface trauma managed? Well, for lid tears, you need to do repair, but when the repair is being done, when I mean you, I mean the surgeon, it's being done, and if the tear is on the medial side, it must be ensured that the lacrimal passages heal properly and are aligned properly. For that, we need to pass on a tube, silicone tube, through a probe in order to ensure that the passages are aligned. That silicone tube and probe is discussed in more detail when we talk about lacrimal system in dry eyes. For lid foreign bodies, we take a 1 cc syringe and it can simply be removed with that. For cornea, if you have UV keratitis that associated with electric welding or doing electric welding, proper eye care is just lubricants and counseling to use eye protection. And if you have a corneal foreign body, you use a 1 cc syringe to remove it. We'll see a picture and a video of how that's done next. So this is a picture on the right which shows how a needle is used to remove the foreign body, which is marked by the arrow. We'll see a little video. So this is the same needle, this is the foreign body. So what you do is you take the eye of the needle facing towards you below the foreign body, and you just push it out of the cornea. Here we go. And the same can be applied to a foreign body on the lid, as we saw before. So now that we have covered blunt and surface trauma, we are talking about perforating and penetrating trauma, and this is usually because of sharper objects or objects with a lot of velocity that can actually enter and also exit the eye. And it's usually dangerous things like, well, not dangerous things, household things like pencils and scissors and knives in the hand of the wrong person that are responsible for most of these injuries. It's usually two people fighting, usually brothers, sisters, or someone in the family, and they're just fighting with sharp objects, especially pencils, and they poke it into the other person's eye. So everyday household objects can be really dangerous. And penetrating injuries are those that only have an entry wound. A perforating injury also creates an exit wound, which requires a little bit more exploration, because if you can't see the object that went into the eye, that means it also went out of the eye and probably lying somewhere in the orbit. So you have to explore those, and we'll see how that is done. And they are usually again caused by sharp objects or objects with have a high velocity or have a lot of force behind them. And because cornea is something that's right in front of it, cornea is the most common structure that is damaged, and obviously the other amount of damage to the eye would depend upon how far the object has traveled within the eye and if or not has it exited the eye. So these are the most common types of things, in addition to household things that can cause a perforating or a penetrating trauma. And metal grinders in Pakistan are at a very high risk simply because they don't wear eye protection. And similarly, masons, I'll show you a picture in a bit of what can happen if you don't use proper eye protection. This is a corneal penetrating injury with iris prolapse. You can see that he probably had another injury right here. This patient is sort of lucky because the iris has plugged the penetrating injury, so that if external things, i.e., even microbes, can't travel within the eye, so the risk of endophthalmitis is much reduced. This is another perforation, and again, a penetrating injury to the eye. And again, you have the iris that is blocking the wound, and again, which reduces the risk of endophthalmitis. We have talked about endophthalmitis, I think, multiple times now, so I'm sure you know what it is by now. This is a repair, and this is a repair of a penetrating injury to the cornea. This was basically because of a patient, this person running into a glass wall, which was so clean that he didn't even think there was a wall there, and this glass shattered and it basically cut the cornea like an egg. And we needed to apply multiple sutures. These are basically monofilament 10-0 nylon sutures, which are what's the word for it? Thin that you need a microscope to see them. So this was a line of the corneal penetration, and also of and is also the plane along which the cornea is repaired. And you can see multiple sutures being applied, one of which is shown by this white arrow. This is a scleral perforation, and you can see the underlying uveal tissue, and this is going to be repaired using sutures again right here. This is not the same patient. This patient also had a limbal damage, which also required repair. But obviously, if you have damage, you need to suture it up, and you use usually a non-absorbing suture. Here, an absorbing suture is used. Perhaps in all likelihood because a non-absorbing suture at the time that the patient reported wasn't available. This is what I was talking about if you don't use proper eye protection. This can happen. I've seen this happen. I've seen a sickle go through the eye as well. So proper eye protection is important. This is an intraocular foreign body. And remember I said you need to figure out where is the foreign body if it has traveled through an entry wound. You need to find whether the foreign body is within the eye or did it exit the eye, creating a perforation. So what you do radiology, you do an x-ray, but you need to do an x-ray in a way to see whether this foreign body is within the boundaries of the eye. So you place a ring around the eye a metal ring around the eye when you're doing the x-ray, so you can get the shadow of the metal ring on your film. And if your foreign body is within that ring, in all likelihood, the foreign body is still within the eye. A foreign body within the eye is called an intraocular foreign body, IOFB. This is a CT scan showing a foreign body that is lying in close approximation to the retina in the vitreous, and this is that foreign body right here. This foreign body right here as visualized. And it needs to be removed. They need to be removed because they are metallic and their ions can deposit in the retina and can be toxic. They're usually not infective because they are at such a high velocity when entering the eye. Remember, these are mostly metal shavings that the velocity and their travel through the air, or their traversal through the air, makes them hot because of friction, and that makes them sterile, which is good. So they don't cause endophthalmitis, but they can be toxic because their ions can damage the retina. So you remove them doing vitrectomy. We'll talk more about vitrectomy when we talk about retinal detachment because it makes a lot of more sense there. But briefly, what you do, you create multiple ports at the level of pars plana, enter into the eye, and remove the foreign body. This is another example of a foreign body. This is a rubber bullet, and this has caused this to the eye. It has basically shattered the eye. It has shattered the eye to an extent that it becomes a non-seeing eye. So in order to see this eye, we needed to apply a clip or a speculum to open the eye. For corneal and scleral penetrating injuries without any retained intraocular foreign bodies, direct repair is sufficient. We've seen the pictures of this, the picture in which we had a corneal repair for a person who ran into a glass wall, or a scleral repair. You can have corneal and scleral damage together, so you repair both of them. If you have an intraocular foreign body, or you suspect that the patient has an intraocular foreign body based on the history, radiological investigation must be done to locate those foreign bodies. And if you have a foreign body in the anterior segment, must be removed with repair, just like repair of the sclera or the cornea. If you have a foreign body in the posterior segment, you need to do vitrectomy with the removal of the intraocular foreign body. The intraocular foreign bodies must be removed because either they can cause toxicity or endophthalmitis, or even both. If you have a perforating injury and the foreign body or the object that caused the trauma ends up in the orbit, needs to be removed, you usually need an orbital surgeon for that, but it needs to be done because these foreign bodies can cause long-term issues and they must be appropriately dealt with. While we're on the topic of trauma and we are sort of concluding it, there is something really interesting which is called sympathetic uveitis, or which was once called sympathetic ophthalmitis. And it's very interesting because in essence, the disease was a damaged eye makes the good eye sympathize with the damaged eye, and so that the good eye also becomes damaged. And that really is what this was until it was discovered why it was happening. So this was seen in any type of extensive trauma to the eye, extensive enough to disrupt the anatomical tissues within the eye. Usually these patients had really affected vision, usually about no perception of light. And what was happening was that a sympathetic reaction was occurring in the good eye, the non-traumatized eye. And this was called sympathetic uveitis because the good eye was sympathizing with the traumatized eye. Now it is known that this happens because many of the antigens that are locked up in choroidal tissues, which are never exposed to the body, after this type of trauma are exposed and antibodies are created against those, which cause this reaction in this sympathizing reaction in the good eye. Those antibodies may enter into through the blood circulation, obviously, into the good eye if given the chance, and incite this inflammatory reaction. This is something similar to the phacogenic uveitis that we talked about when we were talking about complications of an unoperated cataract. Because these antigens, choroidal antigens or uveal antigens, were never exposed to the body before because they were locked up very tight. And it was only after the trauma that disrupted the tissues within the eye that they got exposed, and antibodies were created against them because they were recognized as non-self. There was no process of recognizing them as self because they were never exposed, they were locked up. So what do we do? How do we prevent this? And the surprising thing was that the sympathizing process or this disease started in the good eye between 2 weeks and up to 40 years after the trauma to the eye. Such a long duration, but it was usually after 2 weeks. So the idea is that if you remove the traumatized eye within 2 weeks of the trauma, this sympathizing action could be avoided. And the way to remove this eye is either evisceration or enucleation. We'll talk about both of these in a bit, but this must be done. You must talk to your patient, look, the eye has so much destruction within it, it has no viable vision, and if you don't take this out, even the good eye might be affected. So if I were to show you diagrammatically what this was, so this is a traumatized eye. This is the good eye, and after a little while between, as we said, sometime after 2 weeks, and it has been reported to have occurred after 40 years, this eye starts sympathizing with this eye and develops a uveitis within itself, an inflammation within the eye. We've talked about uveitis, and sympathetic ophthalmitis is a uveitis within the good eye, in response to trauma which occurred in the other eye, trauma enough that caused excessive disruption of tissue within that eye. So we need to remove this traumatized eye within 2 weeks. If we don't do that, this eye can result in potential formation of antibodies against its antigens, which have now been exposed to the body, which were previously locked up, and the trauma basically exposed them. So basically all of these techniques, evisceration, enucleation, exentration, are removing all or parts of the eye. We'll do evisceration first. Evisceration is like opening a can of canned fruit, for example, eating away everything inside and keeping the can. So what you do is take the example of an eye as a can. Opening a can would mean opening the lid. Opening the eye would mean opening the cornea. You give a 360 degrees incision in the limbus, and you take the cornea away and discard it. Now your can is open. You take a scoop, clean everything from within the eye. Remember, it's the choroidal antigens that we are worried about. So you take a scoop and remove all of the choroid from inside, leaving just the scleral shell. Obviously, the lens and everything else is going to come out, including the retina. So the only thing left is the scleral shell and nothing else. And this is usually indicated in an eye that has blind from pain, from trauma, to prevent sympathetic ophthalmitis or sympathetic uveitis, as I've just talked about. It is not used for malignant conditions or cancers which can spread when you open an eye like this. And in case you're wondering, sympathetic ophthalmitis and uveitis are the same thing. I've been using these terms interchangeably if you've been paying attention. So this is how you do evisceration: 360 degrees incision around the cornea, discard the cornea, remove intraocular contents, and what you do after that, you take a silicone orbital implant, push it inside the scleral shell, and stitch the conjunctiva over it. And then you can place a prosthetic eye, an artificial eye. Obviously, it's a non-seeing eye. It's made of various materials, but at least it gives a semblance of normalcy to the patient. This is how an eviscerated eye would finally appear. There is no cornea here because it was cut, discarded. Everything inside intraocular contents have been scooped out. We put an implant inside of this, stitch the conjunctiva on it, and put a prosthetic eye. Enucleation is like removing the entire eyeball. You cut the optic nerve, all the muscles that are attached to the eyeball, and remove the eyeball as a whole. And this is indicated if you have a malignant tumor that's contained within the eye. The most common example is retinoblastoma. And it can also be done in cases of sympathetic ophthalmitis or sympathetic uveitis. Both of them are the same thing. The terms are used interchangeably. They're the same thing. And again, if the trauma is severe enough that you have a risk of sympathetic ophthalmitis or uveitis developing, this is another way of removing the eye. And this is done simply, as I said, by dissecting the conjunctiva away, dissecting the muscles away, cutting the optic nerve. And now that you've removed everything, that orbital implant that we used before to put in the scleral shell, we now put in the orbit and stitch the muscles on it, and we put an implant on top of it. Exentration is the most extensive form of eyeball removal, and it's an eyeball removal together with the adnexa of the eye removal. This is usually seen or indicated in when you have a malignancy that is not only involving your eyeball but also your adnexa. Skin tumor, squamous cell carcinoma is one example in which it is done. And when we talk about removal of all of the contents, it would also imply removing all of the contents of the orbit. So you do a periosteum dissection and remove everything from within inside the orbit, and also the lids or the adnexal tissue. The most extreme form of removal of ocular tissue is exentration, and exentration is removing all of the orbital contents together with the ocular adnexa. And this is done in the most extreme forms of tumor, which has either started off from the adnexa to involve the orbit, or it started off from the orbit or the eyeball as in involving the adnexa as well. One such example is squamous cell carcinoma of the lid, which has gone on to involve the orbit and the eyeball. And this is what happens. You remove the adnexa, all of the orbital tissue, and what you do afterwards is put a skin flap over the defect. This is to prevent infections and also to give some semblance of decency after the procedure. So these are just small diagrams. Evisceration is just the contents of the eyeball leaving the scleral shell. Enucleation is all of the eyeball. Exentration is all of the orbit, including the adnexa. So for sympathetic ophthalmitis or uveitis, we do evisceration or enucleation. And this is a prosthetic eye that can be implanted afterwards. The procedure is complete. The evisceration and the enucleation, obviously, it can't be put in after exentration. Guess which is the prosthetic eye? They are custom designed, these prosthetic eyes. So you go to an artist who takes a picture of your eye and designs a prosthetic eye according to what the other eye looks like. It happens, it is done in Pakistan as well, and really well, if I may say so. Finally, chemical trauma. Chemical trauma is usually because of generally household chemicals, or if you're involved in a trade that involves a lot of chemicals in your lab. One really extreme example of chemical trauma is vitriolage, which is an intent to disfigure and is a crime, but is classified as chemical trauma. We saw we discussed vitriolage when we were talking about, or we will talk about in the future when we talk about ocular surface and lid anomalies, and we will talk about vitriolage in context of ectropion, when your lid margin is sort of uh, pulled outwards. So these are the most common, not comical, most common types of household agents which can cause eye trauma potentially, acids and alkali. So these are the various types. It is somewhat important to distinguish between an acid and an alkali. So you need to ask your patient what caused the damage to the eye. And the reason for that is that acid damage is sort of less dangerous as compared to an alkali damage. An alkali damage can actually perforate an eye, and the chemical can get inside the eye. Acids, on the other hand, tends to form a slough because they are basically proton donors. So they produce slough and water, and that slough prevents acid from penetrating into the eye. So an alkali burn shown on the left produces corneal perforation, whereas acid burns just produce a lot of inflammation. You can see a red eye together with a lot of inflammatory material in the cornea as well as at the limbus, but it hasn't gone inside the eye. So if I were to show you these two animations, alkali can actually perforate the cornea and damage intraocular structures, while acids usually tend to just stay on the surface and cause a lot of surface damage. But at an undergraduate level, it's very difficult, even in a tertiary care setting, it's very difficult to be 100% sure whether that's an alkali or an acid in the eye, and until the patient is carrying the bottle and you can obviously read the label as to what's inside. If you have a litmus paper, you can put the litmus paper in the eye to see what sort of a reaction you do. Acids turn blue litmus red, alkalis turn red litmus blue. But the good part is sort of that as a primary care physician or a family physician, all you need to do is take a bottle of normal saline or whatever fluid you have, put a drip set, and tell the patient to keep washing the eye as you send the patient to a tertiary care center. Your job here, and as I said, there are very few things in trauma which an undergraduate can handle, and you can handle this very easily. All you need is your wits about you. If the patient comes in with a history of chemical trauma, any fluid that you have that you know is sterile, you don't want an infection going into an eye which has a trauma, just put a drip set to it and tell the patient to wash it. Normal saline works best in this case, and you can just tell the patient to keep on washing it as the patient is going to the tertiary care center. Once the patient is in a tertiary care center, what can be done is you give lubricating eye drops together with steroids to provide comfort. You can do amniotic membrane, and you can also apply corneal prosthesis to improve vision and appearance after the trauma has occurred. And these prostheses are very similar to something that you can also use if you have vascularized corneal opacities after keratitis, for visual rehabilitation as well as the appearance of the patient. We're at the end, the miscellaneous category, and the first we'll talk about is called eclipse retinopathy or solar eclipse retinopathy. And this happens because the moon is 400 times smaller than the sun. It's also 400 times closer to the earth than the sun is. So because of this size distance coincidence, the moon, when the sun and the moon and the earth are in one line, the moon is able to completely sort of block out the sun from us. And if you're fortuitous enough to be standing in a location where this happens, you will observe something called a complete or a total solar eclipse or a complete eclipse. And that can be potentially dangerous to you, especially if you try and look at it with your naked eye, which you shouldn't. And the reason you shouldn't be doing it is because it will literally fry your retina. And here is how that happens. So if you're standing here where you're observing a complete eclipse, or any eclipse for that matter, but the danger is more if you're viewing a complete eclipse, this is what you're likely to see. And since today is June 21st, 2020, today is the Ring of Fire Day. Don't look at the Ring of Fire, especially if you're at a well, it's already gone. No point talking about it now. So this is what you're likely to see. And what this does is it creates this darkness simply because the moon is cutting off most of the solar radiation or the sunlight. And what this would do is it would dilate your pupil, because that's what happens to pupil in relative darkness. So this is the size of the pupil in normal daylight, the picture at the top. The picture at the bottom shows the size of the pupil during an eclipse. And actually it can be a fully dilated pupil up to 12 millimeters or more. This is actually more than 7 millimeters, but you get the idea. And what you are doing is you are looking at this nice ring of fire with your eyes open without any protection, and look at the amount of solar radiation that's entering your eyes simply because your pupil is dilated. Under normal viewing conditions on a normal day, the amount of visible radiation is enough, and it is bright enough to cause your pupil to be constricted. Right now, whatever radiation that is coming in is not enough to constrict your pupil. Your pupil dilates in response. So whatever sunlight is coming in, it is going to come in and focus on your fovea, because you're looking at the sun. That's your object of interest, and that's where the rays coming from the sun will focus on the fovea, and it'll raise the temperature of fovea by about 22 degrees, and that's happening because your pupil is dilated. Had your pupil been of normal size, the rise in temperature is about 4 to 5 degrees. And this extreme rise in temperature can literally damage your fovea by photothermal reaction within 30 to 60 seconds. The threshold is 90 seconds. So within that period of time, your fovea will literally fry out, and you will end up with something called a macular hole, because all that radiation focusing in, your eye is acting like a magnifying glass, and all that radiation is focusing on the fovea and is frying it out. And simply the reason here is a dilated pupil. Your pupil does not normally dilate in normal sunlight because of the brightness. Here the brightness is reduced, but you still get solar radiation, as you can see from the picture here, even in a sort of a complete eclipse or a total eclipse. And entering through a dilated pupil, that is enough within 30 to 60 seconds, normally 90 seconds is the threshold, to create a macular hole, literally fry your retina at the macula. So you're not supposed to view the eclipse, not with your naked eye. If you want to view it, use a cell phone camera, use a special eclipse viewer, and these are pretty much relatively cheap if you can find them. And what they do is they cut off the solar radiation entering your eye by a factor of 100,000. So it is safer to view with these, but never without any protection, because you will end up with a macular hole, and since your fovea is fried, you will lose your visual acuity. Depending upon the extent of damage, that person can even go blind. And the management is generally observation. So the precaution here is, don't look at the eclipse directly, or use one of those eclipse viewers, as I've already said, which reduces the amount of sunlight passing through to the retina by a factor of 100,000. The other one is called a battered baby or a shaken baby syndrome, and this is basically, I'm sure you have done this when you did forensic medicine, that if you shake a small baby that you're taking care of, you get a lot of CNS hemorrhages, subarachnoid hemorrhages, and you get similar type of hemorrhages in your retina and or your vitreous, and a vitrectomy may be indicated, as we have talked about before, if the vitreous hemorrhage is not clearing up. One of the consequences of very severe trauma is something called phthisis. And this very severe trauma is something that can result in shutting down of the ciliary body, so that aqueous is no longer produced, so that the eye would sort of become deflated. This is called a phthysical eye, and this is called phthisis bulbi. And when the eye is no longer viable, the body would just shut it off to conserve energy, and this is how it looks like. This is a very extreme example in the right eye of phthisis bulbi. You can't see the eyeball at all, simply because it's shrunken and it's non-seeing. So what's obviously done is enucleation together with the prosthetic eye implantation. So just like at the end of gradual painless loss of vision, we have another table here, and this is for your revision. So I'm just going to uncover it. You can use the PowerPoint of this video discussion and see how many of these conditions can you do on your own without cheating. Thank you very much. This is it. If you have any questions, you know where to ask, and I'll see you in the next video.